I'm supposed to be discussing this overview of surgical management of primary hyperparathyroidism. And to this audience, which is comprised of endocrine surgeons primarily, I will be skipping through some of the issues that I may have listed in this presentation, but I suspect all of you would be very well aware of that. So, is there anyone in the audience who has either not operated or not assisted a surgery for primary hyperparathyroidism? Anyone? Don't. I wonder if anybody is going to speak out. How do I get a feedback from any? Perhaps I'm asking for too much for people to speak out. Is it? Okay, I'll keep going then.
We have assisted, sir.
Great.
Yeah.
So I think majority of you have either assisted or operated, but I was wondering if there's anyone connected in this meeting who has not been experienced, not been exposed to parathyroid surgery so far. Well, I guess for that person, this discussion shall be the most informative. So primary hyperparathyroidism is a condition where there's an intrinsic and autonomous secretion of excessive secretion of parathyroid hormone. And this is secreted from either a single or multiple pathological parathyroid glands. And what sets it apart from secondary and tertiary hyperparathyroidism is that there is a primary disease in the parathyroid gland, and the parathyroids are not hyperfunctional secondary to some other insult, for example, renal failure. The commonest cause for primary hyperparathyroidism is a single gland adenoma, and this occurs in about 80%, 85% of all patients. But then primary hyperplasia can be seen in about 12 to 15% of patients, and rarely they can be a parathyroid carcinoma. And the hallmark of the disease is raised serum calcium and serum PTH levels. And I'll come to the diagnosis a little later. Primary hyperparathyroidism is the third commonest endocrine disorder after diabetes and hypothyroidism. And at least in certain centers in Western world, it is the commonest endocrine surgical disorder. I'm sure some of you would not agree to it, and I too in our practice, this is certainly not the commonest endocrine surgical disorder, but in certain other parts of the world, it is indeed so. The incidence of primary hyperparathyroidism varies, but in North America and Western Europe, this is fairly common disease, and the incidence ranges between 3 and 4.5 per 1,000 per annum. The incidence has been reported to be the highest in certain Scandinavian countries. In India, to best of my information, there's no population-based data, so we do not know what's the incidence. Perhaps we diagnose just the tip of the iceberg. The true incidence and prevalence of the disease in our country is not known. This is because primarily we manage patients who are symptomatic.
FM mode. Bluetooth mode.
Sorry, I could not understand. Yes, is that a question or a comment or somebody's? Okay, so primarily we manage only symptomatic disease, whereas in the rest of the world, at least the developed world, the predominant disease that is managed of primary hyperparathyroidism is managed in an asymptomatic stage, which is detected by routine calcium screening in asymptomatic people. So our patients are primarily overtly symptomatic, and the diagnosis is often made quite late after multiple treatments for fractures and renal calculi, and then only somebody then suspects and diagnoses primary hyperparathyroidism. Long ago, more than 2 decades ago, we published the unique clinical characteristics of primary hyperparathyroidism in the country, which happened to be amongst the first few systematic description of the disease in our country. And we described the unique characteristics like parathyroid cripples, patients who are crippled due to extreme hyperparathyroidism, syndrome of disappearing bones. These are patients with extreme osteoporosis, and on routine imaging, radiography, the bones are not even visible, and that's what we called the syndrome of disappearing bone. And we also reported that the coexistence of vitamin D deficiency and calcium nutritional deficiency impacts the manifestation of primary hyperparathyroidism and results in extreme form of musculoskeletal manifestations. The diagnosis of primary hyperparathyroidism is essentially biochemical. Patients are diagnosed based on the biochemical values, and what is required is to estimate the corrected serum total calcium and ionized calcium. And one single measurement may not suffice. What is required is that we do at least 3 consecutive measurements of total serum calcium and then measure the corrected values and exclude other causes of hypercalcemia. We also estimate the parathyroid hormone levels. There are certain causes other than primary hyperparathyroidism that can result in high PTH levels. These include commonly vitamin D deficiency or insufficiency, which results in mild secondary hyperparathyroidism, chronic kidney disease, hypercalciuria secondary to renal dystrophy, malabsorption syndromes, and then certain drugs such as thiazides and loop diuretics, lithium and bisphosphonates. All of these can have impact on calcium homeostasis, resulting in falsely elevated PTH levels. We also estimate the 24-hour urinary calcium and creatinine, and this is essentially to exclude the familial hypocalciuric hypercalcemia. And coming on, the primary purpose of this discussion today is to discuss the surgical management of primary hyperparathyroidism. I must acknowledge Spandana prepared majority of the slides that I'll be using for a recent seminar that she delivered, and which was moderated by Fareen and me. And I'll be using some of those slides, or rather many of those slides. One can ask, if we are talking of surgical management of primary hyperparathyroidism, and as I said just a while ago, that majority of patients do not have any major clinical manifestations, they are asymptomatic, then why do we even need to treat these patients? The answer to this is that even though the patients may be asymptomatic, but a vast majority of them have one or more end organ damage. And the end organs of parathyroid gland or parathyroid hormone are essentially the musculoskeletal system, the renal system, the excretory system, and cardiovascular and various other systems. And in majority, there is existence, even while the patient is asymptomatic, approximately 2/3 of them have some evidence of end organ damage. If these patients are not treated surgically, or primary hyperparathyroidism is left untreated, there is worsening of these end organ damages, which impact the quality of life of the patients, increases the risk of fractures and renal functional impairment. So these are the reasons why one needs to treat hyperparathyroidism or primary hyperparathyroidism. Parathyroidectomy, by the way, is the only definitive treatment of primary hyperparathyroidism. There are non-surgical options available today, either a close observation or follow-up with no medical management, or medical treatment in certain ways which I will skip during today's discussion. But compared to any of those, surgical management of primary hyperparathyroidism is the only treatment which results in permanent cure or lasting cure of the disease. So it makes sense to offer surgery to almost all patients with primary hyperparathyroidism, barring those where there's any specific reason why they may not require or they may be very high risk for surgical treatment. So why do we advocate parathyroidectomy or surgical treatment of primary hyperparathyroidism? It's primarily because it results in significant improvement in the bone mineral density of the patient, thus reducing the fracture risk. It reduces the risk of recurrent kidney stones, and it results in preservation of the kidney and bone function. There is also possible improvement, or rather quite a bit of improvement in quality of life of patients, cognitive functions, especially in elderly patients, and cardiovascular risk, which can be reduced after parathyroidectomy in patients who have pre-existing cardiovascular disease. So even though the title of this slide says the current perception of indications of parathyroidectomy, you might notice the statement I'm quoting is pretty old, more than 2 decades old. This was an editorial published in New England Journal of Medicine, which stated that parathyroidectomy should now be recommended in 1999 to all patients with primary hyperparathyroidism, based on the dual view that most patients probably have symptoms and that changes in surgical techniques have made surgical treatment simpler and faster than in the past. And this statement is even more true today in 2023 compared to what it was 2 decades ago. The indications for parathyroidectomy include young age, less than 50 years age, patients who have symptomatic disease, either musculoskeletal, neuropsychiatric, renal, or any other manifestations of primary hyperparathyroidism, any possibility or suspicion for concern for malignancy, plus patients who are asymptomatic, but those who have serum calcium more than 1 milligram per deciliter above the normal range or upper limit of a normal range. Such patients who have a T-score of less than or equal to minus 2.5 at lumbar spine or femoral neck or the distal radius, that is, patients who are osteoporotic, patients with any evidence of vertebral fracture, estimated GFR rates of less than 60 milliliters per minute per 1.73 meters square body surface area, urinary calcium excretion of more than 400 milligram over 24 hours, nephrolithiasis or nephrocalcinosis, and patients who are asymptomatic but unable to undergo medical surveillance, or those who desire definitive surgical treatment. This is the standard list of indications of parathyroidectomy, which I'm certain you can find in any textbook of endocrinology and endocrine surgery. But how have we arrived at this list of indications? There's been a series of NIH consensus meetings which have brought out consensus statements. One of the first ones came out in 2002 which listed pretty much all patients with primary hyperparathyroidism, as I've discussed earlier. These guidelines for management of asymptomatic primary hyperparathyroidism, they have evolved from the first consensus statement brought out in 1990 down to the most recent one brought out in 2022. You can see there's been quite a bit of change, and with every passing modification or updation of the guidelines, more and more patients have been added to surgical treatment list. The current AACE guidelines, they say that parathyroidectomy is recommended for patients with neurocognitive and neuropsychiatric symptoms that are attributable to primary hyperparathyroidism, and this is a strong recommendation. And parathyroidectomy may be offered to surgical candidates with cardiovascular disease who might benefit from mitigation of potential cardiovascular sequelae other than hypertension, which is a weak recommendation. And this is over and above the recommendations of the conventional indications, such as uh, conventionally believed indications include musculoskeletal and renal manifestations, and young age, etc., as I said earlier. Other part of these guidelines which are worthy of discussion include the non-traditional symptoms of muscle weakness, functional capacity amelioration. Abnormal sleep patterns should also be considered in the decision making for parathyroidectomy, though this is a weak recommendation. And non-traditional features of reflux and fibromyalgia symptoms can be considered in the decision making, though there is insufficient evidence to recommend surgery for these. So the summary statement of the 5th International Workshop, which was held in 2022, included neurocognitive and neuropsychiatric testing, cardiovascular and metabolic evaluations, and gastrointestinal evaluations. These are not recommended in patients with primary hyperparathyroidism, and neurocognitive or neuropsychiatric manifestations if present should not be by themselves the ground for recommendation for parathyroidectomy. However, patients who have other manifestations along with these or are otherwise desirous of being operated upon, they should be offered surgery. Further, this 5th International Workshop summary statement states cardiovascular or metabolic abnormalities, if present, are not clearly related to PHPP, should not be used as criteria for decision making for parathyroidectomy. And if gastrointestinal manifestations are present, they are not clearly linked to primary hyperparathyroidism unless the patient has symptoms of the disease or patient has multiple endocrine neoplasia syndrome with Zollinger-Ellison syndrome. Another question which might be of interest to some of you is who should be performing parathyroid surgery? This is maybe a bit of deviation from the flow of discussion, but nonetheless, it is pertinent. Parathyroidectomy is a safe and well-tolerated operation and is successful in the hands of experienced surgeons, and cure rates in hands of these surgeons who are experienced in parathyroid surgery exceeds 95%. And this is regardless of setting, that is, irrespective whether these procedures are done in an academic institution or in a private setting, and whether it's and in various other settings, and independent of the operative technique. We will talk about bilateral neck exploration or focused parathyroidectomy and various other forms of operative procedures for primary hyperparathyroidism. Irrespective of those techniques, in hands of high volume surgeons, the cure rates exceed 95%. Unfortunately, surgeons who perform less than 20 parathyroid surgeries, in their hands, the success rates or cure rates come down, and the complication rates also are higher in hands of those occasional parathyroid surgeons compared to surgeons who are well-versed or experienced with parathyroid surgery. Parathyroid surgery is also quite cost-effective. There have been studies which have compared the cost of managing patients with primary hyperparathyroidism utilizing the QALY principle, the quality of life assessed life years measurements, and indeed parathyroidectomy emerged as the cost-effective option compared to non-operative strategies. Moving on, once we have established the diagnosis of primary hyperparathyroidism using appropriate biochemical tests, and we have made a decision that the patient requires surgical management, which means there is one or more indication for parathyroidectomy in that particular patient, Then one needs to decide which procedure to perform. And in the current era, having made a decision for parathyroidectomy, one would embark upon doing localization studies to localize the pathological parathyroid gland. Now, one word of caution, these localization studies or imaging modalities, these are not diagnostic modalities. They do not help in arriving at the diagnosis of primary hyperparathyroidism. These are merely helpful in chalking out or planning the appropriate surgical treatment of a patient who requires parathyroid surgery. So please do not be in this misconception that in a patient who is undergoing parathyroid localization studies, it is with the aim of diagnosing the disease. Rather, it is with the aim of only aiding the surgeon with the surgical procedure. The guiding principle that we use for parathyroid imaging are imaging has no utility in confirmation or excluding the diagnosis of PHPP. Patients with negative imaging results continue to be candidates for parathyroidectomy. Conversely, patients who have, or rather, this what it means is patients who have undergone parathyroid imaging and we have not been able to localize a parathyroid disease does not mean that the patient would not require parathyroidectomy. It merely means that this patient would require bilateral neck exploration and search for the parathyroid pathology intraoperatively and appropriate surgical treatment accordingly. There is marked regional variability in the imaging accuracy. There are certain centers of excellence with excellent sensitivity of parathyroid imaging, and there are certain others with not so good parathyroid imaging quality. Essentially, as I've been saying, imaging is performed only for operative planning, and it has a much lesser accuracy in patients with multi-gland disease compared to those who have a single gland disease. The localization studies which usually are used include one functional imaging and one anatomical imaging. And these include high resolution ultrasonography of the neck, which had a sensitivity of approximately 75% for single gland disease and a much poorer sensitivity of 35% in multi-gland disease, and the overall sensitivity is 70%. Technetium 99 system EV or NIVI scan is the current gold standard for functional imaging of parathyroid gland, and it has an excellent sensitivity, nearing 90 or 95% for single gland disease, but the sensitivity is much lesser for multi-gland disease. And one can use system maybe SPECT CT with the hope, and at least this was the reason why majority of people started doing it, that it has better sensitivity compared to system EB's planar imaging. Indeed, in certain centers, it is so. So having imaged the patients, then we need to define what are the goals of surgical treatment. And the goals include cure of hypercalcemia and hyperparathyroidism. Besides, we also wish to achieve oncological cure. Mind you, the patients have a benign tumor. The majority have a benign tumor or hyperplastic parathyroid glands. If you did not perform adequate surgery, these patients would come back with recurrent or persistent disease, and that is oncological failure. So the goal includes functional cure and oncological cure. At the same time, one needs to avoid any complications such as recurrent nerve palsy, hypoparathyroidism, and also need to manage the metabolic sequelae like postoperative hypocalcemia or hungry bone syndrome. And where in the long run, one would have to take care of the end organ damage that might have occurred due to the disease. What is the role of surgeon in the management of primary hyperparathyroidism? Whatever we have discussed so far can well be done by a physician or endocrinologist. But the surgeon's role conventionally has been to, irrespective of the results of preoperative localization, or even without carrying out any preoperative localization studies, carry out a bilateral neck exploration and using all the surgical experience and expertise which the surgeon would have gained over years, find out the pathological parathyroids and selectively remove them if there's only one or two of them which are pathological, or perform a subtotal or total parathyroidectomy. However, in the current era, this has changed. The surgeon's role has changed to using appropriate preoperative localization and, as and when possible, utilize lesser invasive or minimally invasive approach to parathyroidectomy. So, as I've just to re-emphasize that it is important that we utilize a combination of a functional and anatomical imaging. And if you were to utilize a combination of these and you are able to achieve a concordant imaging or of the same location or same gland based on the functional and anatomical imaging, this has the best accuracy and is most predictive of surgical cure by removing that particular gland. I think I can skip a little bit of the imaging part now. There are certain patients who would require certain preoperative management. Specifically, for example, patients who have extreme hypercalcemia, those who have presented with hypercalcemic crisis or who have serum calcium levels in excess of 13 mg/cent. These patients should be managed, and in the other patients who do not have severe hypercalcemia and hyperparathyroidism, while they're awaiting the localization and surgical planning, they need to be told not to consume excessive calcium containing diet and make sure that they are well hydrated. Those patients who are vitamin D deficient may be recommended to take vitamin D supplementation. But if this is done, it should be done strictly under medical supervision. So there's a small risk of the patient going into hypercalcemic crisis. Patient should also be evaluated for voice or the vocal cord function. And patients who present with hypercalcemic crisis should be managed appropriately to make to bring down their calcium levels to safe limits. Historically, the first couple of parathyroid surgical procedures recorded in the literature included one performed by Felix Mendel in Vienna in 1925 and that on Captain Martel performed by Edward Churchill in the Mayo Clinic later on in 1930s. Coming on to the surgical approaches, essentially one can do bilateral neck exploration to try and locate all the 4 parathyroid glands and any supernumerary glands, and then decide which of them require excision based on the macroscopic assessment in eyes of the surgeon. Otherwise, one can do unilateral exploration of the neck based on the imaging results. If one has been able to localize the disease to one side, one can restrict the exploration to that particular side. But by and large today, what is most often performed is one or other form of minimally invasive parathyroidectomy. The commonest procedure performed is an open mini incision minimally invasive parathyroidectomy, but one can also perform a video-assisted parathyroidectomy or endoscopic parathyroidectomy, radio-guided parathyroidectomy, or robotic parathyroidectomy. Unfortunately, majority of these have much lesser experience, and there are only certain centers and surgeons who are very well versed with these procedures. Now, surgery of parathyroid gland is essentially based on not just anatomy, but a sound knowledge of the embryology of the parathyroid. I'm certain if majority of you are aware of what the embryological origin of parathyroid glands is. And the embryologically, the superior and inferior parathyroid glands differ markedly. There are certain locations in which the utopic or the normally located parathyroid glands are to be looked for. For example, the superior gland is majority of them, approximately 3/4 of them, would be located within 1 centimeter radius circle at, from the point where the inferior thyroid artery and the recurrent renal now cross each other. The other superior parathyroid glands can be found more dorsally in the tracheoesophageal groove. Some of them, especially when they are enlarged, may descend along the TE groove, and so they will be much lower down. And certain of them, a small proportion of them, would be found along the superior thyroid artery, even caudad or even cephalad to the superior pole of the thyroid gland, and rarely they can be intrathyroid. The inferior glands are more variable in their location. Approximately half of them are located along or approximately in relation to the inferior pole of the thyroid gland. But a significant proportion, say about 15%, are found along the thyrothymic ligament, and approximately 7% are found within the superior cornu or the substance of the thymus gland. Rarely, they can also be intrathyroid. These are the locations which we consider as utopic or normal sites for parathyroid glands. But then diseased parathyroid glands can be located in various other locations. And all these locations are essential for a surgeon to be aware of to locate the pathological gland. So the surgical procedure or surgical exploration starts with looking for a diseased gland in the utopic location. Looking also for, when if you're doing a bilateral neck exploration, also need to look for all the normal glands in the utopic location, and then only go on to look for these glands in the ectopic locations if you're not able to find them in the utopic locations. Bilateral neck exploration, by definition, is the standard technique in which all parathyroid glands are identified by way of exploration of both sides of the neck and wherever required of the ectopic cervical locations of parathyroid glands. It provides a time-tested standard of care procedure for primary hyperparathyroidism with a long-term success rate of more than 95% and very acceptable low complication rates. The indications of bilateral neck exploration are numerous. There are certain indications which are absolute, and these include patients who are a known case of MEN1 or even MEN2, patients who have secondary or tertiary hyperparathyroidism. Of course, that is not part of this discussion. Patients where after some previous surgery, where the PTH levels fail to drop, and one has not been able to convincingly locate a single adenoma. Failure to find a diseased gland at the location indicated by the imaging studies, finding more than one abnormal parathyroid during the intended focused or unilateral neck exploration, in absence of any positive imaging studies, in absence of conducting any imaging studies. There are certain patients where you may not be able to even perform imaging studies, and coexisting thyroid pathology, including thyroid cancer or multinodular goiter. There are certain other reasons where it is advocated, but it may not be absolutely indicated. These include discordant parathyroid imaging, unavailability of high PTH intraoperative parathyroid estimation, inability to obtain preoperative imaging, lithium-induced primary hyperparathyroidism, Other forms of familial hyperparathyroidism and coexisting thyroid pathology that may not require surgical treatment, and certain surgeons have a preference for bilateral neck exploration. The principles that we use for bilateral neck exploration, there are certain absolutely necessary points. These include: one must perform bloodless dissection. If there is bloody operative field, it is often difficult to locate the parathyroid glands and safely remove them. Also, at all times, one must be aware of the possibility of occurrence of multi-gland disease. There are certain points which are helpful. These include a low threshold to identify or visually identify the recurrent laryngeal nerve. This is helpful in many ways, because not just for safety or preservation of the recurrent nerve, but also for locating the parathyroid gland, because parathyroid glands are often located based on the depth in relation to the recurrent nerve. The inferior gland is anterior or ventral to the recurrent nerve, and the superior gland is dorsal to the recurrent laryngeal nerve. Often, parathyroid glands have a mirror or identical kind of location on the either sides. So if you have found the right superior gland at a certain location, there's a good chance that you would find the left superior in a mirror image location. When there is a normal appearing parathyroid gland which is found, try to evaluate for an attached adenoma by opening up the periparathyroidal tissue, not necessarily the capsule of the parathyroid, but almost always parathyroid glands are enveloped in a fat envelope. You open up that fat envelope and you might find an adenoma. I'm sorry for. And then one can follow the inferior thyroid artery to the glands by cautiously dissecting this as you go distal from the inferior thyroid artery. Biopsying of the normal parathyroid gland used to be a norm until, say, about 4 decades ago. It can now be done only selectively. Replace intraoperative density tests with frozen section, and intraoperative PTH testing can be helpful. Things to avoid are: avoid relying completely on localization studies. Keep questioning yourself, or keep questioning the localization results, and also be aware that there may be multi-gland disease. Never remove a normal parathyroid gland. Avoid any untargeted thyroidectomies. So the conventional neck exploration at certain stage was the gold standard, but even today, for certain patients like those where there's no parathyroid imaging either performed or successfully performed, this is the gold standard procedure. It has 98% success rate in experienced hands, has a very acceptable cosmetic result too. What you do is a collar incision, raise the flaps, locate. You can either split the straps in the midline or go through a lateral approach where you dissect in between the stenomastoid and the straps, locate the parathyroid glands, and then selectively take them out. This is again showing the utopic location of the parathyroid glands where you want to look for superior ones. Almost 3/4 of them are very close to the intersection point of the inferior thyroid artery and the recurrent nerve. And conventionally, the exploration for the superior gland is started by exploring the tracheoesophageal groove. That is where majority of the superior glands are located. If not in the utopic location, they may be lower down, but along the tracheoesophageal groove. And these are certain other pictures showing the same, an adenoma found in the tracheoesophageal groove. Inferior gland, as I said earlier, is somewhat more variable in location. And again, we start locating, looking for the inferior gland in the lower pole of the thyroid gland. ventral to the recurrent now, and then keep dissecting downwards. And in majority of cases, you will be able to locate it. Once all parathyroid glands are identified, what do? If you find a gland which is enlarged, which is abnormally tan or maroon colored, it is globular in shape rather than flat in shape, and it is abnormally descended with gravity, those are the ones which you think are pathological, and these need to be removed. If you have located 3 normal glands and 1 abnormal one, selectively remove just the abnormal one, and you would have a tumor such as this. Otherwise, if you have been able to find 4 abnormal glands, this is a scenario where you are dealing with primary parathyroid hyperplasia, and you would have to do either a subtotal parathyroidectomy or a total parathyroidectomy. A third scenario that is possible is you may find a single enlarged gland which is either adherent or invading into surrounding structures. This is the scenario where you suspect parathyroid carcinoma and you conduct or carry out an en bloc resection of the parathyroid carcinoma. These glands, which are parathyroid carcinomas, would be dense. They'll be more a grayish white in appearance compared to the dark maroon or tan looking parathyroid adenomas. So if you are suspecting parathyroid carcinoma, straight away can carry out an en bloc resection, and if required, appropriate or selective lymph nodal dissection. So this is a picture showing primary hyperparathyroidism patient who underwent total parathyroidectomy and transcervical thymectomy, and a supernumerary parathyroid gland was also found and resected. This was a patient with MEN1. In certain patients, more often for renal hyperparathyroidism, one can carry out total parathyroidectomy and parathyroid autotransplantation, where parathyroid parathyroid tissue equivalent to 1 normal parathyroid gland is sliced and then implanted in either brachioradialis or sternomastoid, more often in brachioradialis muscle of the non-dominant hand. This is a patient where we suspected intraoperatively that the tumor may be a malignant one. This, what I'm showing with my cursor, is the parathyroid gland, and this one here is the thyroid lobe. And we decided, because there was no plane between the thyroid and parathyroid, we conducted an en bloc resection of this parathyroid and thyroid along with central compartment lymph node dissection. Fortunately, this patient turned out to be atypical adenoma and not a carcinoma. But this is a scenario where an en bloc resection is required. Minimally invasive parathyroidectomy or lesser than bilateral exploration approaches are the current standard of care for patients where you have been able to locate the disease on one side of the neck, and then these patients can either undergo unilateral exploration or a targeted or a focused or a concise or minimal parathyroidectomy. The first reports of these procedures started emerging in 1990s, the early 90s, and these represent a conceptual shift in the way that we no longer consider it as essential to visualize all 4 parathyroid glands, and this procedure can be performed based on the preoperative localization. There are a number of names given to these procedures, but essentially all these different names refer to the same minimally invasive parathyroidectomy, and there's been some effort by the American Association of Endocrine Surgeons to define what is MIP, or minimally invasive parathyroidectomy. Essentially, this is a procedure where you use a small incision, less than 3 centimeters, and you perform focused extent of dissection, not extensive dissection. Use minimal anesthesia, either local or regional, or general anesthesia. This procedure facilitates minimizing the hospital stay, and this also provides an opportunity to perform outpatient surgery for a vast majority of patients with not so severe hyperparathyroidism. One has to rely to a certain extent on operative technology, including the endoscopic technology and the various adjuncts such as the IOPTH, and routine use of preoperative imaging is essential. So in order to perform these procedures, accurate preoperative localization is the key. Without a good localization, you cannot perform safe and effective minimal invasive parathyroidectomy. Patients where there's a concordant imaging based on a functional and an anatomical parathyroid imaging, the success rates exceed 95%. This is an example of a system EB scan. I'm certain majority of you have seen many of these, where you can find a single enlarged parathyroid gland, which is taking up high amount of radioactivity. We used to perform these subtraction imaging. We still perform at times where a paternitated scan is performed and then a system EB scan is performed and the images are subtracted and the remaining is called a subtracted image. Originally, this used to be done with thallium technetium subtraction, but now we use system EB and paternitated subtraction. There are various selection criteria one can utilize. Single adenoma on imaging is essentially what is to be managed with minimally invasive parathyroidectomy. One has to exclude multiple glands, multi-gland disease. There are some relative indications or contraindications for which you would not like to do minimal invasive parathyroidectomy. Certain groups and surgeons, they believe that young patients younger than 30 years should not be subjected to minimally invasive parathyroidectomy, but that's not the majority view. And patients who have familial hyperparathyroidism are often not advocated to undergo minimally invasive parathyroidectomy. The contraindications of MIP include certain absolute contraindications, such as known multi-gland disease, such as in patients with familial hyperparathyroidism and MEN1 or MEN2 syndromes, concurrent thyroid pathology, which requires surgical intervention, and discordant imaging. The relative contraindications are symptomatic cervical disc disease, patients who are on anticoagulation, known contralateral nerve injury, and previous ipsilateral cervical injury, lithium use, or chronic renal failure. So which technique should one use? There are numerous of these. As I said earlier, it's very individual. It depends on an individual's choice, which one would you use. There are patients who would insist on not having any scar in the neck, in which case you can do a scarless in neck surgery or SIN, S-I-N. These can be endoscopic, breast axillary approach, robotic approach, or even transoral. Then the commoner ones that are used are what we call focused or minimal access small incision parathyroidectomy. Commoner one is a lateral incision, but certain people also use a central incision. It can be done, this focused parathyroidectomy can either be done under general anesthesia or local anesthesia. One can use a central or a lateral incision, 2 to 2.5 centimeters. The dissection is usually performed between the strap muscles and the sternocleidomastoid. Recurrent laryngeal nerve is identified, and the tumor, once removed, is identified, is removed selectively, followed by intraoperative PTH estimation. Minimal invasive video-assisted parathyroidectomy, which used to be commonly performed or frequently performed some time ago, is no longer performed as frequently now. This utilized numerous endoscopic ports put in the neck itself. This has been now replaced with scarless in neck endoscopic parathyroidectomies, which include extracervical access through breast, axilla, or combination of the two, or chest wall, or oral vestibule. A radio-guided parathyroidectomy is another option. Again, there was a lot of enthusiasm, say 2 decades ago, but which has faded away, and it's no longer as popular. Total videoscopic or endoscopic assisted parathyroidectomies have the advantage of providing enhanced and enlarged views. And so with current generation high definition optics, it is indeed the parathyroids are seen very well. But small incision, direct incision or direct vision MIP continues to be the most commonly performed minimally invasive parathyroidectomy procedure. Other approaches are video endoscopic approaches, as I said earlier. Now one can ask, what is an ideal minimal invasive parathyroidectomy? To my mind, it is a procedure which is as safe and effective as the gold standard bilateral neck exploration parathyroidectomy, plus the advantage of having a day-only procedure under local anesthesia with a small incision of 2 centimeters or less, with minimal dissection causing minimal pain, and removal only of a single enlarged parathyroid adenoma with 98% confidence of cure. These prerequisites and contraindications we have discussed, and these are just some pictures to show you the kind of incision utilized, and you can find these the details of the operative procedure in one of the relatively older publications from me in ANZ Journal of Surgery 2002. Okay, then I'm skipping through some part of the other preoperative localization, but at times you may find an abnormal parathyroid gland in the anterior mediastinum or even in the posterior mediastinum, and one can resort to endoscopic or thoracoscopic parathyroidectomy in these patients. This was a patient who had a mediastinal parathyroid adenoma, one who had an open parathyroidectomy performed via partial sternal split. And then this is an example of a patient undergoing video-assisted thoracoscopic surgical parathyroidectomy. And this is a patient who had a mediastinal parathyroid adenoma, which was in the anterior mediastinum, located just beyond the innominate vein. And this patient, we could perform a radioguided parathyroidectomy through the cervical incision itself, because almost always these in descended inferior glands are located along the thyrothymic ligament or in the thymus, and one can pull out the thymus gland, and the parathyroid tumor would also be taken out through the same. There can be patients who would experience some complications or morbidity due to parathyroid surgery. The most dreaded complication or morbidity or adverse outcome of parathyroid surgery is surgical failure. The purpose that you started with to cure the patient of hyperparathyroidism is not served. That's what surgical failure is. The rate of or the incidence of recurrent laryngeal nerve injury during parathyroid surgery is less than 1%. Hypoparathyroidism can be seen in about 5% of patients undergoing focused parathyroidectomy to approximately almost 50% patients undergoing total parathyroidectomy and via bilateral neck exploration for primary hyperplasia of the gland. Wound infection and hematoma or wound-related problems can be experienced, but in experienced hands, the overall morbidity, perioperative morbidity, is less than 4%, and mortality is certainly very close to 0%. One can use one or more surgical adjuncts. These include the most important one being the intraoperative PTH estimation. One can also utilize frozen section aspiration, frozen section biopsy, or a fine needle aspiration for PTH estimation during the surgery as an adjunct. In the earlier years, methylene blue used to be used for enhanced visualization of parathyroid gland, and currently the near-infrared fluorescence or infrared spectroscopy with utilizing ICG fluorescence is being used in certain centers. Intraoperative ultrasonography, jugular venous sampling, and radio guidance are certain other ways which can be utilized. And in patients, especially those who are undergoing a second or a third neck exploration and who have a nerve at risk, intraoperative recurrent nerve monitoring can also be utilized. What is intraoperative PTH monitoring? It's a real-time assessment of parathyroid function with and utilizing this, the success rates of minimal invasive parathyroidectomy ranges between 95 and 99%. Using this, the multi-gland disease can also be detected, however, with a lesser degree of certainty. Okay, skipping through, there are various criteria described for intraoperative PTH monitoring. The original Miami criteria described that there's a decay of more than or equal to 50% compared to the highest preoperative or pre-excision values of PTH. What is usually done is one puts in a large caliber cannula, either in the peripheral vein or in the central vein, for intraoperative venous sampling. Before the patient is the anesthesia is induced, a sample is taken, that is a preoperative sample. Then, after dissection of the neck or the tumor, before excision, one more sample is taken, which is the pre-excision sample. Then at the time when you are ligating or clipping the final vein or excising the tumor, that is what we consider as time zero. And 5 minutes, 10 minutes, and 15 minutes from that time zero, we draw other blood samples and then assess the PTH in this using a turbo immunoluminescent assay. Compared to the peak preoperative or pre-excision level, if at 10 minutes, the PTH values are less than 50% or equal to 50%, this is considered curative fall according to the original Miami criteria. Then all criteria, they included decay into the low normal range. Rome criteria included decay of more than 50% and to within reference range at 10 minutes post-excision. Similarly, the Vienna criteria utilized decay of more than 50% from the pre-incision value at 10 minutes post-excision. And there's another Charleston criteria. But the commonest utilized criteria are the Miami criteria or the modified Miami criteria, where when one wants to document that the 10 minutes post-excision value is less than 50% and within normal range. There are certain limitations of intraoperative PTH estimation. It's not very foolproof in patients who have multi-gland disease. And of course, it is costly. It is actually of great value in patients who are undergoing surgery for recurrent or persistent hyperparathyroidism. And in real terms, it provides help in improving success rates only in about, say, 2 to 5% of patients. This is how the PTH is performed. What you do is you chart or note down the levels, pre-incision, pre-excision, post-excision 5 minutes, post-excision 10 minutes, and post-excision 15 minutes, and then plot them in this way. If the 10 minutes post-excision level is less than 50%, and especially if it has come down to within normal limits, that is very highly suggestive of curative fall, with the false positive rates of or false positives of about 2% and false negative about 5%. Intraoperative PTH estimation is not the only way of utilizing PTH monitoring. One can do the same day PTH monitoring, which is more cost effective perhaps. And as I said earlier, in patients who have multi-gland disease, IOPTH is not very accurate. The accuracy comes down to just about 50%. In our patients who are often vitamin D deficient and those who have very high baseline PTH levels, it is often a concern whether intraoperative PTH estimation would be accurate or not. And indeed, there is an impact of the vitamin D levels and very high baseline values of PTH, as well as the parathyroid tumor size. I'll skip a bit of it, but just mention to you that approximately 80% plus patients have a single parathyroid adenoma. About 2 to 5% have double adenomas. About 10% of all primary hyperparathyroidism patients have parathyroid hyperplasia, and less than 5%, certainly less than 5%, in majority of series, about 2% of all patients have parathyroid carcinoma. These are some examples of the parathyroid pathology in our experience. This is a typical parathyroid carcinoma. You can see it's so different compared to the usual adenoma that I showed you earlier. Compared to the rest of the world, the parathyroid pathology in our experience in various Indian centers certainly differs. The tumor size is larger. The incidence of parathyroid carcinoma is higher, and so is the incidence of atypical adenoma. Atypical adenoma, some believe that is nothing but a long-standing parathyroid adenoma with certain changes in some of which may mimic parathyroid carcinoma. In our experience, the parathyroid carcinoma is right now is approximately only about 5% of all patients. Postoperatively, the patients may have eventful post-op period, especially those who have severe osteoporosis or severe musculoskeletal disease due to primary hyperparathyroidism. And these patients may manifest with hungry bone syndrome, which is observed in 24 to 82% of all patients with symptomatic hyperparathyroidism. The maximum fall of serum calcium levels is usually observed within the first 48 hours. I'm sorry for the typographical mistake, 48 hours. And a certain proportion of patients may require intravenous calcium gluconate calcium infusions, besides requiring oral vitamin D and calcium supplements. The post-op management is important. After an apparently successful parathyroidectomy, calcium intake should follow the Institute of Medicine dietary reference intakes. Patients who are vitamin D deficient should receive vitamin D supplements. And at 6 months, a repeat estimation of PTH and, of course, calcium monitoring is done even earlier. This is done to determine the cure of the patient. Post-parathyroidectomy, hungry bone syndrome at one stage in our experience used to be a norm, but now no more than a third of all our patients have hungry bone syndrome. Recurrent or persistent hyperparathyroidism should be seen in less than 5%. There should not be any cause-specific mortality anymore. In initial few years, when we had really sick patients with multi-organ system involvement, they would succumb. There were some patients who succumb, but by and large today, parathyroidectomy is a very safe procedure with almost zero mortality. This is the rate of our persistent and recurrent disease and mortality in long term, which essentially occurred due to patients who had parathyroid carcinoma or those who had progressive end-stage renal disease. And we have reported on the recovery pattern of prostatitis fibrosa cystica. And due to shortage of time, I'm skipping all these parts, and I'm certain we'll find some other opportunity to discuss these things. We've also reported the long-term recovery following parathyroidectomy, as well as what kind of salutary effects parathyroidectomy has on the neuropsychiatric symptoms in patients. So the surgical cure is defined by reestablishment of normal calcium homeostasis lasting a minimum of 6 months. If the patient has high serum calcium and high PTH levels within 6 months of surgery, we consider this as persistent disease. However, after a minimum period of 6 months of normal calcium and vitamin and calcium and PTH levels, the patient has a recurrent hypercalcemia. This is what we call as recurrent hyperparathyroidism. So, in summary, primary hyperparathyroidism is primarily a surgical disease. The diagnosis is essentially biochemical. Patients would require assessment of the end organ damage, followed by, once the patient's diagnosis is established biochemically, it is followed by parathyroid imaging, which is usually done by a combination of ultrasonography and system EV scan. Surgical management can either be in form of bilateral neck exploration or minimally invasive parathyroidectomy, and one has to manage the postoperative hypocalcemia, and the long-term vitamin D and calcium supplementation is required. The key to successful parathyroid surgery is training and experience in parathyroid surgery, knowing very well not just the anatomy of normal and abnormal parathyroid, but the embryological basis of the embryology of parathyroid gland, because often you would have to look for a missing parathyroid gland in those embryological locations. The variant anatomy and pathology have to be very well understood for foolproof surgical or good surgical outcomes. One can utilize appropriate intraoperative aids or adjuncts, including intraoperative PTH estimation. Outcomes are usually excellent, both in terms of functional and oncological outcomes. But of course, there would be anecdotal patients with parathyroid carcinoma or with severe end organ damage who would have less than ideal outcomes.